So my case is a case of inferior valve myocardial infarction in a patient with triple vessel disease and a CTO. So this 56-year-old gentleman, he had a history of 1 year history of effort angina, was admitted with short duration of rest angina. ECG showed ST elevation in the inferior leads with ST depression in the lateral leads, and echo showed multiple regional wall motion, predominantly in the inferior wall and anterior wall with LV dysfunction. So you can see from this angiogram, this radial root, and it shows in CT of the LAD some disease in the circ and RCA which is occluded. So since it was a STEMI inferior wall, we thought we'll tackle the right coronary artery first. So through the radial route, we used a JR, right 6 French Judkins right, and then we pre-dilated the mid-RCA lesion, and then we deployed the stent. And we found that there's a lot of thrombus going down distally, creating no flow. So we used an export catheter and pulled out the thrombus. So when you grade TIMI, thrombus may be grade 4. So the problem with thrombus is can be systemic, causing stroke, limp, or mesenteric ischemia. It can retrogradely embolize into the non-culprit coronary vessels or to the distal coronary tree and cause suboptimal myocardial perfusion. Distal embolization we know can cause slow flow, no flow, increase the infarct size, and cause LV dysfunction. So this slide shows that once you do thrombus aspiration, your myocardial flush grade improves, ST segment settles better, and this interesting slide again showing thrombus embolization, this red line, and no thrombus embolization. So all when you look at all the parameters like death, MACE, stent thrombosis, bleed, everything is less when you have no thrombus embolization. So anyway, we managed to get all the clots out, and then we deployed the stent. This is the final result. We put a 3.5 into 25 or 0 into the right coronary artery. There's a little bit of slow flow, but LAD is filling retrogradely, so we left him at that stage. And then we advised him to go for a possible bypass because his syntax score is high. He refused bypass, so the next sitting we took him, we decided to go through the femoral axis, and this is the image of the left system. So we thought we'll tackle the circumflex first and then the CTO later because the ostium of the LAD was involved, and maybe we would have to stent from left main to LAD. So we stented from proximal L6 to the first OM with a 3 into 30 or 0, and we got good flow. And then we decided to go and tackle the CTO at the same sitting. We used 7 French EBU 3.5 guide. We got a radial axis, and then we cannulated the RCA, and we kept doing retrograde injection to make sure our wire was in the proper position. The main difficulty in this case was this artery had a curious 90-degree turn here, and it was very difficult to turn this wire down here. So we used a microcatheter under a Fielder XT wire, and then we managed to get into the true lumen. We made sure that it's in the true lumen. Here it's in the diagonal now, so we pulled back and got it into the LAD. Finally, we did PCI with 2 stents, 2.7540 distally, and overlapped with 3 into 15 from the ostium of the LAD. We didn't get into the left main because we got good results there. There's no plaque shift. The only issue was there's some amount of dissection in the diagonal, with probably wire induced, and is already deceased earlier. So we left it at that stage because we didn't want to do a bifurcation in a CTO. So the message is whether to do a culprit-only revascularization or a complete revascularization in these patients with STEMI. So most of these trials, over 10 trials, have shown that there's no definite mortality benefit, but some reduction in MACE, mainly due to need for TLR. So theoretically speaking, multivessel disease can occur up to 40 to 60 patients with 60% of patients with AMI. And multiple plaque ruptures can happen. And when this happens, you can get compensatory, there is absence of compensatory hyperkinesis of non-infarct territories. So it can lead to heart failure, death. And both the ACC-AHA 2013 guidelines as well as the ESC 2014 guidelines say that when you have cardiogenic shock and pump failure, it's better to do multivessel PCI. So, but again, it has its problems because when you use a lot of contrast, you prolong the procedure, final results are often not so good. And so this culprit shock trial is the latest trial which shows that composite death renal failure actually increases when you do multivessel PCI then. So however, our patient was not in cardiogenic shock except for a short period of hypotension when there was thrombosembolization distally. This is managed effectively, and he improved, and we adopted a culprit-only revascularization followed by stage revascularization of the vessels, and he's doing quite well 6 months down the line. Thank you.
Great. Quick question. I'm curious, do you guys have balloon pump availability there, and the thought for not using it in a CTO to LAD, culprit right, critical circ?
We have an IABP, we don't have an Impella. So in fact, it was kept ready. Patient's hemodynamics were good and it was not in failure. We are confident that in case an IABP is required, we can put it in fast. So it's all kept ready.
Yeah, I think
the idea was to do the procedure and come out fast.
Yeah.
As long as the hemodynamics.
No, and certainly you got through it very nicely, and staging that LAD CTO I think is absolutely the right thing to do. You don't want to get into a CTO after you've fixed a culprit right from a contrast radiation and operator fatigue standpoint. I would say the one thing I would have probably done is make sure there was a second access for an IABP should you have needed it, because it's really hard to put in when you're doing CPR, which is certainly a possibility on a guy with a huge right prox occlusion, LAD CTO with collaterals from the right. So that would be, I guess, one feedback that I would have. I don't know if you guys have any other points or comments.
With the I tend to individualize with balloon pumps or Impellas. I mean, from all the latest data, it showed that in shock, there's no benefit if you do a pump or not with primary PCI. But I totally agree with you. I think you got to individualize each case. And I think our practice in the last 5 years, I think we've decreased the use of pumps during STEMIs and in Impellas. But again, it's based on the papers that have been published. But again, it's one of those individualized each case. And this one would have never probably been enrolled in a study CTO with a huge right and so forth. So.
Yeah, I think the thing to remember too is obviously this case is different because the right was feeding a huge territory, not just the right, but the entire LAD territory. So in a case like this, if a patient decompensates hemodynamically, it's almost certainly going to be related to LV failure. But in a typical right coronary artery infarct, the reason they fall apart is because of RV failure, not LV failure. And so balloon pumps and Impellas oftentimes don't give you much help. Most of the time, all they need is some fluid and time, potentially a right-sided Impella if they're fully in shock, or worst case scenario, even a ECMO. But in this case, because it was feeding the entire right, you got to have a low threshold to quickly evaluate the LV EDP, and consider hemodynamic support.
Yeah, and that's going back to, I think you mentioned it with the right heart cath. If you're worried about RV failure, because their mortality from the shock original trials is just as high as LV failure, is get a right heart cath hemodynamics. And one thing we've learned at least in our practice, is we tend to go back to the floor, we'll watch, we'll look at the numbers, we wait, and then when we go put the RPM pellet, it's too late, and they're spiraling, and they don't survive. So be proactive and move quicker than later, and I think we're starting to learn that the hard way, at least in our institution.
So, Thomas, that was a great presentation. You obviously saved the best for last. The CTO was always the most fun. The MI is never fun because it's usually in the middle of the night, and they're usually sick. The thing I wanted to say that I thought was most instructive with that CTO PCI is the most important thing you did is you put a second catheter in. Don't try to do anything and think you're going to antegrade wire it without knowing where you're going. Particularly, and it was highlighted because of how tortuous that LAD is. You may not have even known where you were going if you didn't have that second catheter in. The question I had for you was, what was your strategy going to be if you weren't able to wire antegrade?
Well, you would have thought of retrograde, but it is not a very long CTO. We're pretty confident of tackling it antegrade.
Yeah, I think that one was a little challenging. It was, probably from a JCTO standpoint, I'm off the top of my head, I think it'd probably be a 2, just with the tortuosity and the lesion length. But it's always good to remember to think 2 steps down the line. What are you going to do when my initial approach fails, and then what am I going to do if my bailout approach fails? And so in this case, you've got excellent retrograde visualization. I think you could do dissection reentry. You could star the vessel. You could go retrograde. All of those are reasonable options, but it's important to have an algorithm in your head of what you're going to do when your initial approach fails. And so fortunately, you were able to make it around that bend and get a beautiful result.
We would have probably taken them for a second sitting with retrograde approach.
Yeah. Oh, good.
Thank you.
Yeah, go for it.
On the same note, let's say if on the right side the RCA was full of red clots and the aspiration catheter worked really well and saved you, but let's say it did not, what would be your next choice to aspirate those clots? Is there any experience with intracoronary TPA or intracoronary 2B3A or angiojet? What would you do in case if you just that classic aspiration won't work?
Well, we don't have, we have tried intracoronary TPA. Angiosculpt we don't have in our place. So we tried TPA with results so and so. Some guys benefit, some patients really don't benefit.
Yeah. I think with a fairly straightforward clot like this, a manual aspiration catheters work great. I'm not a big fan of angiojet. I just never have seen it work, ever. The one new device that's out is the CAT-RX by Penumbra, which is a fantastic device for large clot burdens. That would be the thing that I would probably go to next. And then I think intracoronary 2B3A inhibitors, this is the one rare case where intracoronary 2B3As is still useful to have on the shelf. So that would have been my approach.
Yeah, 2B3As, the good thing, there was a trial that showed IC versus IV, and it, not, the good thing is it showed to be as safe, as effective, at least let you know that you can do it, you're not going to harm. I have tried angiogen, some crazy cases of just thrombus filled out in these aneurysmal, and I agree, you always have a lot of clots still left. It's not the best, but the one thing is put a pacer in, because I've had some long pauses that don't just come back from coughing or atropine, so just keep that in mind.
Yeah, I think Penumbra is fantastic. It's the first aspiration catheter that works consistently. Sometimes with the manual aspiration you get clot, sometimes you don't. Angiojet, I've had the same experience, give or take it works, but Penumbra, I've had a lot better success, and I think 2B3A IC is fine. The other thing is if you can get flow in that vessel, get TIMI-3 flow back even with a residual lesion, I mean, this guy could be a candidate for bypass still, especially if you haven't loaded him. If you're using IV 2B3As or Cangalor or something like that to get you through the case, and you get flow back in the vessel, park him upstairs or wherever your unit is, get a surgeon involved, and they'll operate on him in 5 days. Maybe.
Maybe.
Yeah, I don't know. In our institution, our surgeons are very comfortable operating on oral antiplatelet therapy, and so we never really have an issue with loading.
Any of them looking for a job? Love to get one of those at our institution
Yeah,
because
yeah.
you can't. And they had the quote data from a New York State registry that patients with acute MIs don't do well with bypass surgery. You have to wait 5 days. Because by 5 days, the ones that are alive will do fine with bypass surgery.
Natural selection.
It's hard to explain that to them.
Yeah, and I mean, it has become our routine for our hybrid procedures too. We do the PCI
Culprit.
on day 1, day 2, they get their bypass and they're already loaded on Plavix. And I did a case actually just 2 days ago with a colleague of mine, and he had limited conduit, and so we were going to stent his circ, and then he was going to get an off-pump lima, and he was going to be sent for potential RCA, CTO, PCI if he had residual angina, and ended up working on his circ, dissected it, and ended up having to put quite a bit more stents. And the original plan was to put him on Cangrelor overnight, but we decided to go ahead and just load him on Plavix. And my surgeon, I asked him, "Are you concerned about Plavix now?" He's like, "No, because he'll be on it tomorrow." So he's like, "If you don't load him, I will." So, okay, fair enough. Hey, let's go.
I do think it comes down to the surgeon's comfort level. When I was before at Ohio State, I was at Vanderbilt, and we had published a paper on the hybrid, which was the first hybrid, U.S. adult hybrid OR in the USA, and everybody was loaded with clopidogrel with opening the chest. And as time went on, if you look at with several months and up to a year of experience, when you looked on beyond that, there was no difference in chest tube drainage, no difference in transfusions, no difference in bleeding. And I think it really comes down to the comfort level of the surgeon, and then to know what to expect when you go in the OR.
I think there are certain exceptions, obviously, if it's a redo chest.
Yeah.
And then they're going to be a little less comfortable with that.
All right.
Great.
Yeah, thank you.
Yeah, thank
Thanks,
you.
everyone. Great cases. Congratulations.